Again, this is the paper that we are referring to understand better Whiplash is a great paper, and it gives us um ideas how to tackle Whiplash patient, not tackling and making the patient to fall and get injured even farther. And that's not what I'm talking about, is the tackling of the treatment plans. This is, as we mentioned before, originally, the title is Central Pain Due to Injury of the Spinothalamic Tract, which was misdiagnosed as complex regional pain syndrome. And again, is the case study. And we didn't mention about the complex regional pain syndrome, what it is. And so we're trying to understand this one at the basic level, and then possibly in the next videos we'll be talking about the complex regional syndrome, what it is, how it is being formed, and in more detail. And the complex regional syndrome, in 1872, the American Civil War physician Mitchell, Dr. Mitchell, he first described that as the causalgia, which is something causing the pain. And it is the cause of that. He mentioned is a traumatic partial nerve injury. And so if somebody has a nerve injury in the nerve, which is referring to the uh, axons, bundle of axons in the peripheral nervous system, that is causing the pain in the patient. And in the affected extremity, he noticed that it shows some feedback to the pain, and it has some type of trophic symptoms, which is not only in the area of the where the pain is coming from, it is spreads out in the area and the larger territory. Uh, so that is mainly due to the inflammatory process that the brain not only being affected, and which gives that effect to the peripheral nervous system, but also at the more localized feedback that the body is trying to uh, take care of itself, but with the inflammation, and that inflammation it causes some type of trophic symptoms, and which we will talk about that in next few slides shortly. And early in the last century, Dr. Sudak um described the similar symptoms with extremity pain, and developed, which was the syndrome, the pain syndrome developed after a distal bone fracture. And so that cause was not the nerve damage anymore. It was the fracture that caused the similar type of syndrome. So the complex regional syndrome, it is not only peripheral nerve damage in that case. It also can be caused by some type of non-nerve type of structures like the bone fracture. So at least we have two different causes for the complex regional syndrome, and but these are not the only two type of causes. And so they found out that this type of complex regional syndrome that the patient suffers with a sympathetic reaction that the patient experiences, which causes dystrophy. and can be treated by a sympathetic block, and which uh, is the indication that sympathetic nervous system is the uh, source of uh, those type of dystrophy that the patient experiences at the different regions of the body. There are two types of complex regional pain syndrome, at least, that usually they are being talked uh, at the conferences, and they are more general and more understood type of syndromes. And one is the type 1, the other one is the type 2. And as you notice that the type 2 is the causalgia, which is due to the injury to the peripheral nerve, and the other one is more of the reflex sympathetic dystrophy, which is developed by some type of remote body injuries, and which means that it is not caused by the peripheral nerve damage, but it is something that is happening somewhere in the body, and then that is being referred or has the effect at the other regions, which is more likely would be distal part of that injury site than the proximal, but it spreads out in the regions distally as well as the proximally. But in most important and more complex scenario, CRPS would be a central nervous system caused, and if somebody has the trauma to the brain, like the whiplash, they also experience CRPS type of syndromes, and that is more difficult to diagnose, and but this was the reason that the paper that we are referring to had a harder time to have understanding of what the problem with the patient is. So they misdiagnosed that as the peripheral rather than the central CRPS. These are the syndromes that patient is going to feel pain, and that's why it is called the complex regional pain syndrome, which is almost always is associated with pain that the patient is suffering, and usually it is happening one extremity, but that is not true in the condition of the central complex regional pain syndrome, which is going to be more general, and it can happen uh, half of the body or the whole body, depending on how the extent of the injury to the central nervous system is. And again, uh, as it's mentioned on the second statement, it can be a central lesion, like a spinal cord injury or the brain injury, in condition like a stroke or whiplash. And it is clinically characterized by sensory, autonomic, and motor disturbances, which means that all aspects of the peripheral nervous system will show some type of response to the injury. And then either it is caused centrally or it is being caused peripherally. Uh, the effect will travel to the central nervous system and in many different ways and change the functionality of the nervous system centrally, which is going to be causing a more complex scenario for the patient. The sympathetic nervous system plays a key in maintaining pain, and uh, at the same time, sympathetic nervous system, which is very helpful for people to deal with the fight and flight, but it also is the major cause of the pain in many cases, because hyperactivity of the sympathetic nervous system itself can cause pain due to the uh, bringing inflammation to the areas and attracting the pain fibers to the areas that new vascularization is coming to the area for recovery. All of those factors and elements can bring the pain in the area, either causing allodynia or hyperalgesia, or both. And after the primary central lesion, there are secondary peripheral changes that happens if somebody has a central CRPS. The diagnosis is very difficult in many cases because there is no gold standard for the CRPS syndromes and dysfunction, and especially if it is the central issue, which is more difficult to imagine what the problem is and where the problem is, and because of the complexity and overlapping of the other symptoms that the patient might have that could mislead the clinician to other, the type of um, diagnosis, and which may not be the case for the patient. So the patient become misdiagnosed. The earlier the diagnosis is being done correctly, the better output and outcome the treatment will have, because the chronic case in the CRPS cases, it is more difficult to treat them rather than uh, detecting those uh, diagnosis at the earlier stage of formation. We're going back to the paper that we are referring to as the reference, uh, how the whiplash can affect someone's life, and how clinicians should be more careful of doing their own part to diagnose the patient correctly. Here's the patient history during the um being treated by the clinicians from the onset, where the patient felt pain in the legs and mild weakness in all extremities and memory impairment. And but the thing is that having an acute case of the peripheral damage, it should not cause memory impairment. And usually, memory impairment with the peripheral issues, it comes at the later time. It takes months or years after the injury, if the pain persists for that long. Then it was 8 years later, and the patient was diagnosed for CRPS type 1. And as you recall, type 1 is different from type 2. Type 2 is more causalgia due to the peripheral nerve damage, whereas the type 2, uh, I'm sorry, type 1, it is more of the unknown per se cause of the CRPS, and it is could be the soft tissue damage like musculature, tendon, or ligaments, or heart trauma like a fracture of the bone, which can cause the CRPS in the region. And so the patient felt hyperalgesia, and which means the exaggeration of the pain, and there was a mild edema in both legs. Now you're dealing with the more uh, extent of regions of the body, and if it is a peripheral, would be more localized, more a region than regions. And now the patient is suffering in both legs. And then the patient also experienced the motor weakness in both legs. And after 8 years, and usually if it is a peripheral damage, the recovery would be faster. And but 8 years later, the patient feels a very global effect in symptoms, and that would be more a concern scenario, and more hint to the clinicians to redirect their thought process into the central nervous system. Then it wasn't the year after that, they diagnosed the patient with DTT imaging, and they noticed that uh, some there are some tracks damage in the study, and right and left spinothalamic tract damage, which again, when we talk about that briefly, that this tract which travels up from the spinal cord to the thalamus, which then does many different impacts on brain, including the pain sensation that patient feels is being damaged. So there's a tract that in the central nervous system, it shows there's a damage to it. And again, not only the sensory tracts are affected, the corticospinal tract, which is more of the controlling the different aspect of the motor output. And as we mentioned that before, it also affects the sensory and autonomic nervous system as well. But it again is bilateral, corticospinal tract. And then if it is a bilateral, you would expect that that would be more uh, bilateral findings than the ipsilateral or unilateral, I should say, finding in the patient. And then there are also right and left cortical reticulospinal tract, which is again more primitive area of the brain, which deals more of the vital system, and which includes the autonomic nervous system than the newer part of the central nervous system function. Then it shows that there is a damage to the left fornical crus, uh, and that fornix, which is a structure of the Papez circuit, it is very essential part of the memory construction, and then the patient is going to have some suffering in recall and or continue memorizing of new information. And so that those would be the symptoms that the patient is going to experience. So again, the pain in the right arm is the scenario for that. After 9 years uh, later, the trauma that the patient suffered, and then the pain in both legs, which are all both of those are dealing with the sensory dysfunction, more general than one region. Then there are experiences of the tingling, burning, which are also part of the pain fibers, which is the spinothalamic tract, and associated with that tract also would be an indication of the damage, and allodynia and hyperalgesia, which we previously discussed that. Mild weakness, it could be due to the hypertrophy and of the peripheral structures, and but in this case, it is found in four extremities. But again, this is not only legs and only one arm; it is all four extremities are showing weakness, and again, that should be a very uh, red flag for the clinicians not to focus on the peripheral damage, but also look into the central damage. So, without having the TT imaging studies, the clinician should not simply look for the CRPS of the peripheral issue, either type 1 or type 2. And then, yeah, there's edema is happening in both legs. It could be due to the peripheral reconstruction and adjusting or dysfunctioning due to the central nervous system damage, or it could be because of the vasculature dysfunction due to the autonomic nervous system not functioning correctly due to the central nervous system dysfunctioning of the reticular formation. Again, we said that reticular formation, which is the primitive part of the central nervous system, deals with the primitive function of the body, including the autonomic nervous system. So, if the autonomic nervous system is not doing well, the vascular dysfunction, it is the uh, indication of the dysfunction of the autonomic nervous system. And so, if the blood vessels are not doing the job and give the flow to the body, then the body will be suffering the most and all over, and not only one region. Again, the memory impairment, it is due to either chronic pain that the patient might be suffering, which affects the limbic system, but also DTT indicates that there is left fornical crus damage, which definitely can cause the memory impairment. Again, this is the picture of the DTT that there is the figure caption right here, and you can this side right here is the normal. This is the imaging from the patient, and you will see that compared to the normal, the fornix, and this is the cortical. Reticulospinal tract, corticospinal tract, and even the spinothalamic tract, they are not uh, fully intact, and there's a significant change after the trauma. These are the author's notes that there was a misdiagnosis, and and therefore they only look at the peripheral at the beginning. They should be also studying the central dysfunction in the patient, and that uh, is including the brain whiplash injury, and due to the acceleration deceleration during the accident, which affects the not only the neck but also it affects the brain to shake during that trauma, and that caused the central shock. And then you have to deal with the neck, but also you have to also deal with the um, central nervous system, and the author talks about different type of avenue to do the more clear or better clear diagnosis, and that those are listed here. And by DTT, which deals with the tractography, which is imaging of the tracks, the axons, and pathways within the central nervous system, would be a better choice for the whiplash, which affects the central nervous system. Pain can be caused by many type of causes, and central and the peripherally. But the central pain usually is not something that the clinicians are trying to find with the whiplash accident. And they're all looking for the peripheral damages mainly, like the either nerve damage or the soft tissue damage to cause the pain, and then the nerve is carrying the information to the central nervous system as a pain experience. And but the thing is that the uh, indication in this patient, it is all referring to the central pain and like memory impairments, global effects, and edema in many areas, and then with the other type of findings, which more indicative of the central nervous system, like seizures, cranial nerves dysfunctions, and a more severe case in the gait dysfunction, and then it goes to the cortical level, which deals with the fine motor skills, or also dealing with the sensation in more detail and more complex. If they are not functioning correctly, they should be giving the clues to the clinician that the patient is suffering centrally. But one thing that I need to add to this one, that it is not either or. It could be a combination of the central and peripheral dysfunctions. So even though the paper is talking about the misdiagnosis by the clinicians that it is a central, not a peripheral. But I don't see that it is enough information, or there is enough information that would rule out that the patient is not suffering the peripheral pain syndrome, and so patient possibly could have both of the scenarios. We discuss briefly the spinal sensory tracts. And one of those that we mentioned was a spinothalamic tract that carries pain information to the higher center, and it's the ascending tract. What is important about the reference that we just discussed is that any damage along the distance of this tract and pathway as a whole can cause pain. And we had a patient that had a very small lesion in the thalamus, in the area of the VPL. Uh, on MRI, the patient suffered huge amount on the contralateral side of the body, a huge area, region in the upper and lower extremity that was just caused by one very small damage and lesion in the thalamus. So any damage along this pathway, all the cortex, can cause pain. And in this case, the patient, the imaging studies show that has the damage to this tract. Finally, whiplash. What are the take-home lessons? Do a diligent examination. Without doing the correct examination or the right examination, or doing the fully needed examination, we are going to be having some difficulty with diagnosis, and unfortunately, most of the time, is going to lead us to misdiagnose the case. Think peripherally as well as centrally, and in many cases, people that have or clinicians that have difficulty or have hesitation to move into the central nervous system. Uh, and possibly it is because they don't feel comfortable with the central nervous system function. So, just thinking about peripherally, the patient will suffer a lot if there is the problem with centrally. Utilizing the tools that you have, the better tools, more sensitive, more specialized type of tools, it can give us a better diagnosis. So don't be hesitating or have the fear of using more advanced tools because without those, it still give us some misinformation, or we are assuming that we know what it is, but truly it is something else. Earlier you come up with the right diagnosis, you will have an earlier right treatments plan for the patient. And if that happens, the patient would appreciate you more because the patient will progress in a positive way faster. And the quicker that you perform those treatments, the patient is going to be getting out of your office much sooner. And they are going to be very appreciative of what you do. Do not jump into conclusions, and if you don't have all the facts and all needed facts. So always search into finding and analyzing the case and re-examine the patient's scenario and symptoms and signs so you have a better understanding of what needed to be done for the patient. And again, look into all the facts and for better understanding, which is going to lead us to better diagnosis and better treatment plans. Know your stuff, and more knowledge, it is giving us better understanding what to look for, and sometimes uh, expanding of all the possibilities out of the what is needed sometimes can be distraction. So don't narrow down to very limited of understanding, and at the same time don't expand it too much that it would be taking you away from your goal, which is making the patient's life easier, pain-free, and get them better as soon as possible. Thank you for listening, and you have a wonderful day.